Hi, I'm Dr. Schreiber, and welcome to Littleton Radiation Oncology. You know, when a woman has breast cancer, the first thing we like to look at is what is it? What kind of a cancer do you have? You know, the most common types of breast cancer are infiltrating ductal carcinoma, which is a type of breast cancer that starts in the ducts of the breast and then invades into the fatty tissue next to the ducts. And another common type of breast cancer is what we call ductal carcinoma in situ, or DCIS. This is a non-invasive breast cancer, but a cancer that needs to be treated to be cured with radiation management or surgery. And this type of cancer also starts in the ducts but does not invade into the fatty tissue of the breast. And therefore it has a very low to almost no chance of spreading to some other part of the body. There are many other types of breast cancer that a woman could have, but they are much less common. When you come into this office, we would review the pathology report together to determine what type of cancer that you have. The next thing we look at is where has this cancer spread? And the most common thing to look for is lymph node spread. And the way we do this typically is through the surgeon using what's called a lymph node sampling or a lymph node dissection, or sometimes people call it a sentinel node biopsy. In this type of surgical procedure, we determine the number, if any, of lymph nodes that are involved with breast cancer to help us determine a prognosis and also a treatment plan that's right for you. Thirdly, we look at the chance of spread to some other part of the body using various tests of blood tests or perhaps x-rays as a chest x-ray or CAT scan, or even in some cases what we call a PET scan to look for spread any other part of the body. When we have all that data together, we can what we call stage your tumor. And stages come in 4 categories, and we label them 1, 2, 3, and 4. And stage 1 and 2 breast cancers are the most amenable to local management with radiation. And of course, we would go over that together when you came in for your consultation. After we determine what it is and where it is, then we want to determine number 3, which is what we're going to do about it. Now, with breast cancer, we look at it as 2 different types of diseases, even though it's only one disease. One type of disease is a systemic disease, a disease that affects your whole body. And for that type of management, we look to the medical oncologist, a type of cancer specialist who delivers systemic management such as chemotherapy, which is drug therapy, or hormonal therapy, which are drugs like tamoxifen that alter the hormonal environment in the woman's body. The other way we look at this disease is as a local problem. And the local problem is generally handled with surgery alone, what we call a mastectomy, where the entire breast is removed, or with a combination of surgery and radiation therapy. With surgery and radiation therapy, typically the surgeon will simply remove the lump that we call a lumpectomy or an excisional biopsy, and we follow that up with radiation of some kind. Now, the 2 main types of radiation that we deliver in this office, and they're delivered worldwide, are what's called external beam radiation, that's treating from the outside in, and there's brachytherapy, which is treating from the inside out. External beam radiation typically treats the whole breast in its entirety, and sometimes the lymph nodes as well. And in this office, we usually reserve external beam radiation for those women that have increased risks of spread outside the breast that require a broad field of radiation to treat. The other type of radiation, brachytherapy, is mainly used for tumors that have a low likelihood of spread to some other part of the body, and so they're generally small tumors or localized tumors. Maybe lymph nodes can be involved, but no more than 3 lymph nodes involved, and the patient would generally have chemotherapy along with the brachytherapy in the situations where the lymph nodes are involved. But they are still a brachytherapy candidate. At this point, I would like to focus in on external beam radiation and what that's about. When a woman comes in for external beam radiation, the first thing we do is a planning session. On that day, we place the woman on the CT scanner, and we do a CT scan of the woman in the exact position that she's going to be treated in. We make marks on her skin for that day only, and those marks come off the same day, but we do leave a couple little tiny dots on her skin that we call tattoos. They look like little freckle dots. They're permanent, and they're on there each day to help us line you up, or the woman up, with our laser beams to make sure that the fields are precisely set each day with no change. The woman is then given a choice of treatment times. She picks one that's right for her, and that's the same time every day for treatment. Then she is sent home for 1 to 2 weeks while we do some computer calculations. And in this office, we use what's called intensity-modulated radiation therapy to do those calculations. This is a very advanced form of 3-dimensional conformal external beam radiation, and a form of radiation that allows us to bend the radiation beams around the chest wall and away from the heart as much as possible, while focusing those beams on the entire breast and possibly the lymph node groups around the breast, while still sparing as much normal tissue as possible. After the 2 weeks have completed and we've done all of our planning, the patient comes back in and we do a picture-taking section the first day on the external beam management machine that we call the linear accelerator, which produces high energy x-rays. And then the next day we start in with the actual treatments. And once we start those treatments, even though the lady is coming in Monday through Friday, she sees the physician, me or my associate, on one day only. This is Mondays, typically just before or just after treatment, to see how she's doing. The patient would also see a nurse one other day during the week, generally on Fridays, to see how she's doing as well. When we would see the patient, we would ask if you're having any side effects from the treatment. Now, side effects are related to where we aim the beam. In your case, if we're aiming it at the breast, that's the only place a woman can have side effects. In other words, she wouldn't lose hair on her head from this type of treatment or get sick to her stomach or have diarrhea. But she could get red skin, she could get a slight cough, she could get a little bit tired from these treatments. Those are all short-term, treatable, and reversible side effects. The long-term risks are much less likely, but still possible. There's a 1% chance of something called an asymptomatic rib fracture. That's a rib that can actually break and then heal itself again. It's usually not noticed by the patient, but can be picked up on a chest x-ray or a bone scan done later down the line, and is sometimes worrisome for cancer spread. But when we know about it, we can safely assure the patient that it's just a radiation complication that is not dangerous in itself, but something to be looked at and remembered. The next risk is shortness of breath. This type of radiation with external beam must skim along the outer part of the lung to treat the breast effectively, even with intensity modulator radiation. So there is a small but real chance that a little bit of scarring can develop in the lung, which could cause some shortness of breath. This problem is generally worse in smokers than in non-smokers, but that risk is approximately 1 to 2% in smokers, and in non-smokers less than 1%. Now, if you have a left-sided lesion, in other words, involving your left breast, your heart can also be affected by the external beam radiation. Again, it's a small chance, and it usually only affects the outer part of the heart, but we take great precautions to prevent as much of the heart as possible from being in the radiation field, but it's impossible to prevent all of it from being in the field. Finally, there's a small risk, maybe 10 to 20% chance of something called pleurisy, which is occasional sharp jabbing chest pain that can occur anywhere from 1 to 3 months after the radiation is completed. It may last for 1 to 3 months before it goes away. It is not dangerous or serious in any way, but it can be quite scary to the woman because it feels like her breast cancer is coming back, and then we just simply reassure the patient, and we can also treat that with medications such as non-steroidal anti-inflammatory agents. Now, that's all external beam radiation therapy. The other type of radiation therapy that we deliver is called brachytherapy. Brachytherapy is more complicated treatment, more intense treatment, but much shorter treatment. It also is a more limited treatment. In other words, it doesn't treat the entire breast that external beam radiation does. It only treats a portion of the breast, and it treats that breast from the inside out. Because we use radioisotopes to deliver this type of management, which are implanted temporarily inside the breast, we have a much lower chance of complication in the surrounding tissue. In other words, there's virtually no risk to the heart, virtually no risk to the lung with this type of treatment. It is also given much more quickly. It's given over 5 days. As I neglected to mention with external beam radiation, that type of treatment may last for approximately 6 to 7 weeks of 5 days per week treatment. Whereas with brachytherapy, it only lasts for 1 week, but it's twice a day for 1 week. Now, before we start the brachytherapy, the first thing that we do is an ultrasound pre-plan here in the office. On that day, I will ultrasound your breast. It's a painless procedure, just from the outside in, and look at your biopsy cavity and measure that and determine how many catheters I'm going to use to deliver the brachytherapy. You'll also meet the nurse on that day and go over all your pre-operative testing. Now, I say pre-operative, although it's not really an operation putting in those catheters. You're awake the whole time, and we also use local anesthetic, but it's still some information that you need to know before you have the catheters placed. That pre-operative session is usually done a few days before the actual procedure. On the morning of the procedure, you will arrive in this office approximately 7 a.m. or before. The nurse will prepare you properly on an examining room table and have your skin numbed up with some cream. And then she will prepare your skin area with some betadine, and we will clean up the area in preparation for the local anesthetic administration, which I will do. After the appropriate portion of the breast has been numbed up adequately, I will place a series of needles under ultrasonic guidance deep to the biopsy cavity as visualized by ultrasound, usually 5 or 6 needles. I will also place an additional 5 or 6 needles superficial to that biopsy cavity. After all the needles are in good position, I will afterload them with a series of hollow Teflon catheters that look like this. These catheters have a button at one end, and they are flexible. They replace the needles within the breast in one clean motion. When you look at your breast from the outside, you would see a tiny button which holds the catheter to the skin. If you could look inside your breast, you would see a catheter moving through the middle of your breast, Then on the other side of the breast, we would place another button and then cut off the extra tubing. So what you would be left is simply a series of hollow tubes within the breast. After all the tubes are in good position, this portion of the procedure is terminated. You then walk down the hallway to our CAT scanner, where we will take a series of images using our CAT scanner of your breast with those tubes in place. We will also take a series of measurements at that time. The CAT scan time will be approximately 1/2 hour to 45 minutes. Then you are free to do as you please for the next hour and a half to 2 hours as we do a set of complicated treatment planning maneuvers on our specialized three-dimensional computer. This type of treatment planning is done in conjunction with our physicist and our dosimetrist. After we determine the exact proper placement of radiation for you and the timing of the treatment, we call you back in to initiate your first treatment. This is usually in the later part of the morning. So to reiterate, the actual procedure of placing those hollow Teflon catheters is approximately 45 minutes to an hour. The CT time is approximately 1/2 hour to 45 minutes, so you're done with the CT usually by around 9 o'clock, 8:45 in the morning, and we're ready for our first treatment usually by 10:30 or 11 a.m. When you come in for the treatment, you come to the specialized vault that we have, which has thick concrete walls for shielding, and we lie you on a comfortable bed. We will then hook up your catheters to a series of cables that emanate from a machine that has the radioisotope within it. At that time, I will tell you the length of time for the treatment, which is usually 5 to 10 minutes. And then we will leave the room after a series of checks, which are somewhat complicated for the first treatment. It may last for 5 or 10 minutes. And then we'll turn on the machine and actually deliver the first treatment. Approximately 5 or 6 hours later, you will return to our office for a second identical treatment. Then, over the next 4 days, you will come back twice a day, usually once in the morning and once in the afternoon, separated by approximately 5.5 to 6 hours between treatments for each of 8 additional treatments. So therefore, by Friday afternoon, you will have received 10 treatments over 5 days. After the 10th and final treatment, I will remove those catheters from your breast, and this does not require any anesthetic. I will then place a bandage over the breast and send you home overnight Friday night, and Saturday morning you can remove that bandage at home and then shower normally. Now during the week you are allowed to shower, but we don't like the water to splash directly on the catheters, but can be next to it. Usually women simply just take sponge baths during that week to keep things clean. Now the risk of the procedure is a risk of bleeding or infection because we do poke holes in you, but those risks are less than 1%, and we do put you on preventative antibiotics during the week to prevent those infections from occurring, and we really never see those in our office. There's also a risk of discomfort, of course. You're going to have foreign objects in your breast for that week, and we do give you pain medication to help manage that. Most women are on pain medication around the clock for the first 24 to 48 hours, and then just take regular extra-strength Tylenol as needed during the remainder of the week as your body becomes accustomed to the placement of those catheters within the breast. Sometimes when we initially place those catheters, it can cause some swelling in the breast, and therefore we usually put patients on Decadron for approximately 48 hours. Decadron is a steroid that prevents swelling in the breast. Now those are all the short-term reversible risks of the procedure. Again, there's no risk to the lung or the heart with this. Now the long-term risk is very rare. There's a small risk of thinning of the skin that we call skin atrophy, and that can occur sometimes in rare situations where the radiation source is too close to the skin. When that occurs, you can get a shiny appearance to the skin or maybe even some dilated blood vessels. Again, we rarely see that in this office as we have much experience with this procedure, having done many hundreds of these, and we know exactly where to place that isotope so it doesn't put the skin at undue risk. The second type of risk, again, we've never seen in this practice, but it is reported up to 5% of the time, is a risk of something called fat necrosis in the breast. Fat necrosis means the fatty tissue in the breast actually dies and feels like a lump or is sometimes painful to the woman and can occur several months after treatment. It's treatable initially with antibiotics, in worst cases treated with hyperbaric oxygen, and in severe cases actually removed as an lumpectomy, but it's not cancerous condition. Again, we haven't seen that in our practice. However, that is a risk of the treatment. Therefore, the risk involved with this treatment is very limited to just where we put those catheters, and that makes this a relatively safe treatment when compared to external beam radiation. Now, comparing this treatment to external beam radiation, the advantages of brachytherapy is that it's quicker, again, done in only 5 days compared to 6 to 7 weeks of external beam radiation. It can be done prior to any chemotherapy if you are a chemotherapy candidate, and therefore when you're done with the chemotherapy, you are done with all of your therapy. It also only treats a portion of the breast, and therefore, if in the unlikely circumstance you should have a recurrence elsewhere in the breast, you would still be another candidate for brachytherapy again in another portion of the breast. Or you could have a mastectomy if it recurred in the exact same quadrant. What we found through many different studies that have been done over the past 15 or more years with this treatment is that when people recur after external beam radiation, they tend to recur in the exact same quadrant where the cancer used to be. That's why brachytherapy is shown to be so effective, because it's very rare to see a cancer recurrence outside the initial quadrant of disease. Finally, the cosmetic results with brachytherapy are far superior to external beam radiation when done in the proper hands. In other words, it's a very operator-dependent procedure. As I've described this procedure to you today, you can see that it takes a lot of skill and experience to place those catheters properly and in the right order and in the right distance from each other to allow for the best cosmetic result possible. But what we see with brachytherapy is, because it treats from the inside out rather than the outside in, that all the scarring that should occur, which is not much, is deep within the breast. Very little scarring on the skin. So not only does the breast look natural 5 years, 10 years later, but it also feels natural 5 or 10 years later, as compared to external beam radiation, where the breast may look good 5 or 10 years later, but to the woman it tends to feel always heavier or slightly firmer. So for those reasons, whenever a woman is a candidate for brachytherapy, I prefer to recommend brachytherapy, because I think the overall results, cosmetically and success-wise, are at least as good as external beam radiation, but far less time-consuming and less expensive than external beam radiation. Hopefully this has been giving you a good comparison of brachytherapy versus external beam radiation in the localized treatment for breast cancer. At this point in time, we will now proceed to the consultation room, while I will tailor a recommendation to your specific needs. Thank you very much for listening today. And now I'd like to speak with you about a new form of treatment for breast cancer, a treatment that I've spent 2 years developing. We've been doing it now for at least 2 years, and we've had excellent results. This is a way to treat early-stage breast cancer with just one treatment. It only takes about an hour, but it does require a minor operative procedure, usually under general anesthetic or conscious sedation. The way we do this procedure is we plan to place permanent seeds within the breast. This gives off the radiation dose very slowly over approximately 3 to 4 months. Therefore, no tubes are needed to be placed into the breast for several days, and no back and forth treatments to the clinic twice a day for 5 days. That previous treatment I described was an advance compared to external beam radiation therapy that we previously described. This treatment is now a quantum leap forward, a treatment that allows you to be treated in only 1 day for breast cancer. Prior to this treatment, we do a planning process. This process involves a CT scan and an ultrasound. The CT scan is done first, where we place you on the CT scanner table and align a specially made template to your chest wall and breast area. This alignment is used to place needles at certain angles within the operating room. The needles look like this, and they are placed through the template while you're asleep and into the area of interest of the breast. We need to do that CT scan to determine the proper alignment of that template and needle. After you have the CT scan, we then take you to our ultrasound machine, where we visualize the biopsy cavity or the area of interest within the breast, and we use the same alignment device with the template to correlate the pictures that we take on the ultrasound with the CT scan that we've previously performed. After your ultrasound and CAT scan, either on that day or within the following few days, you will meet with one of my nurses for what we call a preoperative visit. On that day, some preoperative testing will be performed, and the nurses will explain to you about what you can expect on the day of the procedure. On the day of the procedure, you will arrive at the surgery center as an outpatient and then be taken to the operating room. Once you are on the operating room table, we will align you up with our breast device and place the template on the outside or lateral portion of your breast. Through this template, we will place a series of needles through the template, through your skin, into the area of interest, into the breast. We may use 6 to 10 needles. After the needles are in position, we will then insert a series of seeds that have been especially correlated and planned for your particular area of interest that we create in the operating room using a special stranding device. These seeds are called palladium seeds, and they're very low energy seeds with a very short half-life. And they look like this, very tiny. These seeds remain in the breast permanently. The needles are then removed. The radiation will be given off by those seeds over approximately 3 to 4 months. And the radiation from the seeds dissipate very rapidly. After you wake up from the procedure, you are taken to the recovery room, where you have a short recovery as an outpatient for approximately 1 to 2 hours. You are fitted for a specially shaped bra that will shield the area of interest, and you will wear that bra for approximately 6 weeks. Although the radiation emanated is very weak, we still want to protect people that are closest to you, and we ask you to wear that bra while you're around other people. After you go home, we ask you to take it easy for a couple of days and then resume normal activity. After approximately 1 week, you can resume strenuous activity. At about 1 week, we have you return to our clinic for a post-operative CT scan to verify the position of the seeds, and we can determine the distribution of the dose to the area of interest within the breast. After that, you're seen approximately 8 weeks after the procedure for follow-up, and then every 3 months for 2 years, then every 6 months until 5 years have elapsed. With each follow-up, we will do appropriate testing to check for recurrence of cancer, and these include generally laboratory tests, an occasional chest x-ray, and of course routine mammograms. Side effects from the procedure are quite minimal. The short-term risk is a very small risk, less than 1%, of bleeding or infection. We do give you antibiotics to prevent infection. Pain is also minimal, and we give you a small amount of Tylenol or Tylenol with codeine to help with the minimal amount of pain you may experience for approximately 1 to 2 days after the procedure. The long-term risks of this procedure are also quite rare. There is a small risk of injury to the tissue deep within the breast that we call fat necrosis. This mimics a cancer recurrence, but it is easily treatable and is very rare. In fact, we have not seen this complication within my practice. Another long-term risk is thinning of the skin if a seed happens to be placed too close to the skin. We call this skin atrophy or telangiectasia. Again, we have not seen that in this practice because we place the seeds deep within the breast, far enough from the skin, so the radiation dose to the skin is really quite insignificant. Therefore, our long-term cosmetic results have been excellent. Worldwide, many hundreds of women have been treated with this technique, particularly in Canada and Belgium. Now, in this country, there are several institutions also performing the technique as it gains in popularity. The reason this procedure will become popular is because it's quick, it's easy, it's very effective, and the cosmetic results are unsurpassed. So, if you qualify for this procedure by having an early stage breast cancer, please give us a call and we'd be happy to evaluate you here at Littleton Radiation Oncology. Thank you for watching this video, and we look forward to hearing from you soon.